Welcome back to the deep dive. Today, we are doing something a little different.
Hmm.
Usually, we take this broad look at a topic or a new trend, but today, we are going vertical. We are drilling down into the bedrock of medical science.
We certainly are.
We are taking on a titan.
We are diving into the Guyton Hall Physiology Review, 4th edition.
And for anyone in the medical field or, anyone who's just spent way too much time watching medical dramas, that name Guyton is heavy.
Oh, yeah.
It's basically synonymous with how the human body actually works. But this isn't just the textbook. This is the review book. It's essentially a massive collection of questions and clinical scenarios.
Right. And that distinction is crucial. The textbook is the encyclopedia. It's where you go to learn the theory. This review book.
Huh?
This is the stress test. It's designed to see if you actually understand the physiology well enough to apply it, or if you've just memorized a bunch of flashcards.
It forces you to synthesize.
Exactly.
And that is our mission today. We're going to try to crack the code of the human body. We're going to synthesize this massive field, from the cell to the heart, the kidneys, everything, and use this Q&A format to pull out those high-yield concepts.
Think of it as a masterclass in the machinery of life.
Yeah.
We aren't just listing facts, we are looking at the mechanisms. How does the body maintain balance? And more importantly, what happens when that balance breaks?
I love that. Okay, let's start at the very beginning. The microscopic level. One of the biggest themes in the source material is this idea of control.
Homeostasis.
Yeah.
It's the central dogma of physiology. If you don't have it, you don't have life.
Right.
But the source breaks this down with a surprisingly engineering-heavy concept called negative feedback gain.
Okay, let's unpack this because the math here threw me for a loop at first. The source gives an example. A gain of negative 3.0. What does that actually mean?
It sounds abstract, I know, but it's the best way to measure how effective your body is at fixing mistakes. Let's walk through it. Say there's a disturbance, maybe a sudden drop in blood pressure.
Oh.
Without any control system, let's say the pressure would drop by 4 units. That 4 is your potential error.
So the problem is a 4.
Right. But your control system, like your baroreceptor reflex, kicks in. It fights back. In this example, it corrects the problem so well that instead of dropping 4 units, you only have a remaining error of 1 unit.
So it fixed 3 units and left 1 unit of mess behind.
Precisely. And the formula for gain is the correction divided by the remaining error. So the system corrected -3 units.
Negative because it's opposing the change.
Exactly. And the remaining error is 1 pi to 3 divided by 1 gives you a gain of negative 3.0.
So practically speaking, the higher that negative number, the stronger the system is.
You got it. A gain of negative 2.0 is decent, but some systems, like body temperature control, have gains that are essentially negative infinity. They're incredibly precise. The key takeaway here is that disease is basically what happens when these loops fail.
Disease is disrupted homeostasis.
That's it.
That sets the stage perfectly. Now, let's zoom in on the cell itself. The source material paints a much more complex picture of the cell membrane than you might think.
It's not just a plastic bag holding water. The source breaks down the composition specifically. 55% proteins, 25% phospholipids, and 13% cholesterol.
Wait, 55% protein? That's wild to me. It's more protein than fat.
It has to be. Those proteins are the workers, the pumps, the channels, the receptors. But one thing the source highlights that often gets ignored is the glycocalyx.
That's the fuzzy coating on the outside, right?
That's a good way to put it, yeah. It's this negatively charged carbohydrate coat. And it's not just decoration. The source points out it's crucial for cell interactions and, importantly, for the immune system. It's how your immune cells recognize self.
So if that coat gets damaged,
your immune system might start attacking your own cells.
Speaking of attacking things, let's talk about the cell's cleanup crew, lysosomes.
The stomach of the cell.
The source mentions a really tragic but illuminating case study of a 5-year-old boy. He has this accumulation of fats, cholesterol, esters, and triglycerides in his liver and spleen.
This is the classic presentation of woman disease. It's a deficiency in a specific enzyme called acid lipase.
And this highlights how the lysosome works, right?
It does. Lysosomes are filled with digestive enzymes that only work in an acidic environment. That's a safety mechanism.
So they don't digest the whole cell if they leak.
Right. But in this boy's case, the acid lipase is missing. The cell can eat the fats and debris, a process called autophagy, but it can't actually digest them.
So the trash compactor is full, but the crusher is broken.
Exactly. The cell literally gets stuffed full of fat until it can't function. It just shows that physiology isn't just about what you build, it's about your ability to recycle.
Before we leave the cell, we have to touch on the instruction manual, DNA. The source brings up two very specific components, telomeres and miRNAs.
Both very high-yield concepts. Telomeres are the protective caps at the end of chromosomes. Their job is to prevent the genome from deteriorating every time the cell divides.
Like the little plastic tips on shoelaces.
That is the perfect analogy. If those fray, the DNA unravels. Then you have miRNAs microRNAs. These are tiny, just 21 to 23 nucleotides long.
And they are the regulators.
They're the stop signs. They don't code for proteins. They repress translation. They bind to messenger RNA and basically say, do not build this. It's a crucial off switch for genes.
Okay, so we have control systems, structure, genetic regulation. Let's get things moving. Let's talk about electricity, the Nernst potential.
This is really the physics of the nervous system. You just have to remember the fundamental chemical gradients. Extracellular fluid, the soup our cells swim in, is basically ocean water.
High sodium, high chloride.
Yep, and inside the cell.
It's high potassium and high phosphate?
Exactly. And that difference, sodium out, potassium in, is what creates the electrical potential across the membrane. The Nernst equation is just the math of the battery that runs your brain.
And when those nerve signals hit a muscle, things get really interesting. The source material compares two conditions that look similar but have totally different mechanisms, myasthenia gravis and Lambert-Eaton.
This is a favorite for medical boards because the distinction is purely physiological. Both cause muscle weakness, but the location of the failure is different.
Okay, let's break it down. Myasthenia gravis first.
Myasthenia gravis is a postsynaptic disease. Your body produces antibodies that attack the acetylcholine receptors on the muscle side. The nerve is shouting, contract, perfectly fine, but the muscle has its hands over its ears.
You can't hear the signal.
Because the receptors are destroyed.
And Lambert-Eaton.
Lambert-Eaton is presynaptic. The antibodies attack the calcium channels on the nerve terminal itself.
And why does that matter?
Because calcium is the trigger. The electrical signal hits the end of the nerve, and calcium has to rush in to release the neurotransmitter. In Lambert-Eaton, that calcium door is locked. The nerve tries to shout, but it can't release the message.
So one is a shouting problem and one is a listening problem.
That's a great way to put it. And the source mentions the tensilon test using edrophonium. It blocks the enzyme that breaks down acetylcholine, so it floods the synapse with extra message.
And if it's a listening problem?
Having more volume helps the few remaining receptors hear it, and strength temporarily improves. That points to myasthenia gravis.
That is fascinating. Now, while we're on muscles, we have to talk about efficiency. Smooth muscle, like in our blood vessels, has this trick, the latch mechanism.
This is the aha moment for smooth muscle. Imagine holding a heavy box. Your biceps, a skeletal muscle, would get tired and shaky because it needs constant high-energy signals.
Right.
Smooth muscle is different. Once it contracts, it can engage this latch mechanism. It essentially locks the actin and myosin fibers together. It can maintain force with very low energy and very low signal.
So like a parking brake?
Exactly. It's crucial for things like maintaining blood pressure. Your blood vessels need to stay clamped down for hours or even days. If they burned energy like biceps, you'd starve to death.
Speaking of blood pressure, let's move to the engine room, the heart. The source material dives deep into pressure-volume loops.
These loops are the visual language of cardiology. You see the heart filling, contracting, ejecting, and relaxing.
And the width of that loop is the stroke volume.
Correct. Stroke volume is just end diastolic volume, how full it was, minus end systolic volume, what's left after the squeeze.
A phase that always trips people up is isovolumetric contraction.
Isovolumetric, same volume. It's that split second where the ventricles are squeezing, pressure is building like crazy, but all the valves are closed. No blood has left yet.
It's the buildup.
It's the buildup before the explosion of ejection.
Now let's connect this to the clinic. Pulse pressure, the difference between your top and bottom number.
Right. The source clarifies that pulse pressure is determined by two main things, stroke volume and arterial compliance.
Compliance being how stretchy their arteries are.
Yes. So think of two scenarios. First, atherosclerosis. Your arteries turn into lead pipes. Compliance drops. When the heart pumps, the walls don't stretch, so pressure skyrockets. Pulse pressure widens.
And second example?
Aortic regurgitation. The valve leaks, so blood flows back into the heart. This overfills the heart, which means huge stroke volume on the next beat. That massive volume swing also widens the pulse pressure.
I want to touch on a practical scenario from the source, the standing up reflex, orthostatic physiology.
It's a beautiful sequence. You stand up, gravity pulls blood into your legs, Less blood returns to the heart. Cardiac output drops.
And the body panics.
Controlled panic. Baroreceptors in your neck sense the pressure drop. They signal the brain to activate the sympathetic nervous system. Heart rate shoots up, blood vessels constrict, and blood is squeezed back up to the brain.
But the source contrasts this with renovascular hypertension. This is where the kidney gets involved, right?
Yes, and this is a crucial distinction.
Yeah.
If you have a stenosis and narrowing of the artery feeding your kidney, the kidney thinks your whole body has low blood pressure.
So it screams for help.
It releases renin. Renin ramps up angiotensin II, which clamps down on vessels and triggers aldosterone to hold on to salt and water.
Wow.
The result is massive hypertension, all because one kidney was confused.
That is a perfect segue to our next section, the filter, the kidneys.
The master chemists.
We measure their performance using GFR glomerular filtration rate.
Right, usually with creatinine clearance. And the kidney has its own internal reflex called tubulo-glomerular feedback. If pressure rises, it autoregulates its own blood flow to keep GFR steady. It protects itself.
But let's get into the detective work, acid-base balance.
This is where you have to look at the pH in the bicarbonate. Take a diabetic patient with ketoacidosis. You have low pH and low bicarbonate. That's metabolic acidosis.
And the body tries to fix it.
It tries to compensate.
Yeah.
If the metabolism is making acid, the lungs try to blow off acid as CO2. The patient starts breathing heavily deep, rapid breaths.
Kuzumal breathing.
Yes, they are literally trying to exhale the acidity to fix the pH.
The source also mentions the anion gap.
It's a calculation that helps you distinguish what kind of acid is there. A high anion gap means there's some strange unmeasured acid present like ketones in diabetes, or salicylates in an aspirin overdose.
Let's stick with kidney hormones. Aldosterone holds on to sodium. But what about Conn's syndrome, where you have too much aldosterone?
Primary aldosteronism.
You'd expect these patients to just swell up like a water balloon from all the salt and water retention, right?
You would, but they don't. And this is a key concept called sodium escape.
Sodium escape. It sounds like a prison break.
In a way, it is. Initially, the high aldosterone does cause fluid retention. But as the volume expands, the heart stretches and releases ANP. And the high pressure itself forces the kidney to excrete sodium pressure natriuresis.
So the body overrides the aldosterone.
Partially. It overrides the fluid retention to stop you from exploding, but it doesn't fix the hypertension or the low potassium. So the patient is hypertensive and hypokalemic, but not swollen. That's the diagnostic clue.
We're moving fast, but I want to hit systems integration. Respiration. What actually drives us to breathe?
You might think it's a lack of oxygen, but under normal conditions, it's actually carbon dioxide. The source notes that CO2 is the main driver. It can multiply your ventilation by 8-fold.
So we breathe to get rid of the trash, CO2 not just to get the goods, oxygen.
Exactly. Low oxygen only really kicks in as a driver when it drops significantly below 60 millimeter Hg. The system is designed to keep pH balanced by managing CO2.
The source also discusses VQ ratios, ventilation to perfusion.
Right. Gravity matters. Blood falls to the bottom of the lung. So the base of the lung has high blood flow and the apex is less. This creates a gradient where the VQ ratio is low at the bottom and high at the top.
Moving to neurology, the blood-brain barrier.
It's not just a wall, it's a highly selective gatekeeper. The source identifies astrocytes as the key players, along with tight junctions. They stop most drugs from getting into the central nervous system.
Which is a double-edged sword.
It protects the brain from toxins.
Right.
But it makes treating brain infections incredibly difficult because the drugs just bounce off.
And reflexes. The source contrasts the flexor withdrawal reflex with the stretch reflex.
The stretch reflex is a simple knee jerk. Muscle stretches, signal to the cord, signal back, muscle contracts. The flexor withdrawal is when you step on glass.
Painful.
Pain receptors fire, the limb pulls away. But, and here's the cool part, the crossed extensor reflex kicks in. The other leg extends to support your weight so you don't fall over. It's a coordinated spinal dance.
Finally, endocrine. We have to talk about cortisol and thyroid hormones.
Cortisol is the stress hormone. But the thyroid distinction is high yield. P4 is the abundant storage form, long half-life.
Yeah.
But T3 is the active worker. Shorter half-life, but does the heavy lifting.
In the clinical vignette for growth hormone excess acromegaly.
It's fascinating. It's not just big hands and feet. The source points out the metabolic effects. Growth hormone causes insulin resistance. So these patients often have high blood sugar, a form of diabetes, along with the increased protein synthesis.
Okay, we're in the home stretch. Let's look at sports physiology.
The extreme stress test.
The source mentions cardiac reserve.
This is how much your heart can ramp up its output. In elite athletes, cardiac output can increase to 300% or even 400% above rest. It shows just how over-engineered the heart is.
And oxygen debt.
That explains why you keep panting after you stop running. You borrowed energy from anaerobic sources, creating lactic acid. Now you have to pay it back, using oxygen to restore everything.
All right. We've covered a massive amount of ground, but we promised a review exercise. This comes directly from the source's principles on body fluids.
Let's do it. This is a classic medical school trap.
Here's the scenario for you, the listener. A runner loses 2 liters of sweat, and remember, sweat is hypoosmotic, it's mostly water. Immediately after the race, the runner drinks 2 liters of pure water.
So 2 liters of sweat lost, 2 liters of pure water gained.
The question is, what happens to their intracellular cell volume? Do the cells shrink, swell, or stay the same?
Think about the osmolarity.
I'll give you a second.
Yeah.
Walk us through it.
Step 1. Sweat loss. Since sweat is mostly water, losing it leaves the remaining blood hyperosmotic, concentrated, and salty.
Okay, so initially the blood is concentrated.
Step 2. Drinking pure water. Pure water has 0 electrolytes. When you dump that into the system, it massively dilutes the extracellular fluid. The osmolarity plummets.
So now the blood is watery and dilute.
Step 3. The shift. Water follows solutes. Since the inside of the cells now has a higher concentration of solutes than the dilute blood outside, water rushes into the cells.
Right result.
Intracellular swelling.
Yeah.
Cellular edema. The cells puff up. This can be dangerous, especially in the brain. It's why athletes drink electrolyte solutions, not just water.
A perfect example of physics meeting physiology.
It really is.
So let's recap. We started with the cell with that NECA 3.0 feedback gain, the mathematical proof of our body's obsession with stability.
We moved to the latch mechanism of smooth muscle efficiency in action. We looked at the mechanics of the heart pump and how stiff arteries widen pulse pressure.
We saw the kidney's detective work in acid-base balance and that sodium escape in Conn syndrome.
And we finished with the hormonal controls and the immediate consequences of fluid shifts in an athlete.
What is the one thing you want the listener to walk away with after this deep dive?
It's that physiology is not static. It is a constant series of adjustments, of compensations. When you see a symptom, like Kussmaul breathing, don't just see the symptom. See it as the body's desperate, intelligent attempt to correct a deeper error. Understanding that correction is the key to diagnosing the problem.
The symptom is the solution trying to happen.
Exactly.
Thank you so much for joining us on this deep dive into Guyton and Hall. Stay curious, keep learning, and we'll see you on the next one.